What is up, you guys, and welcome to a brand new episode of the Fit Women's Weekly Podcast. I am very excited for this episode. This may be one of my favorite episodes in a really, really long time. And it is not just me sitting here in front of the camera today. I do have a guest on. I have Dr. Rachel Selman, who is a physical therapist, but she also specializes in pelvic health as well as post-pregnancy recovery, especially for athletes or women who intentionally move their bodies. Now, what is so special about this particular episode is that Dr. Selman has created something that no one else has done. We've all heard the idea that during pregnancy, you shouldn't work out beyond raising your heart rate to a certain level, or you shouldn't lift past a certain amount. And we all know nowadays that that's kind of old school thinking, but what is the new school of thinking? What does the research say? So Dr. Selman is the first person to actually create a timeline for not only during your pregnancy of what you should be doing to have the healthiest pregnancy, but to also feel your best. But she also dives into postpartum health as well, so that we're no longer going to that 6-week appointment and then just being told everything looks great. Just because something is normal doesn't mean that it is right. Does that make sense? So she breaks it all down. What can you be doing as soon as you have a baby that's going to help set you up for proper recovery so that you can get back into doing the things that make you feel like you and doing the things that you love. Now, even if you have never had a baby, even if you don't plan on ever having babies, this is still a really, really important episode because this is something that obviously we can all share with people that we do know. I've already shared the actual report with several of my friends who just recently had babies. So I'll make sure to link the information down below. That'll take you directly to her timeline. Again, it divides everything week by week. But I'm getting ahead of myself. Let's go ahead and jump into this episode. Of course, make sure that you subscribe to the channel, give this video a like, and go check out Dr. Selman after you finish listening. I know that you're going to want to. I came across your report from last year about maximizing recovery and postpartum period. And I'm like, this is so amazing, like to actually have a timeline that has never been created before. So I'd really love to pick your brain a little bit about that, but also talk about some of the previous setups, like where 140 beats per minute when it comes to pregnancy, 25 pounds. Like that means that if you're having your second or your third kid, you can't pick up your children, right?
Exactly.
So I want to break down some of that stuff and then what got you into focusing on creating the new timeline and really where did that information come from? Because I know that doing research on pregnant women is what's held us back for so long, the dangers of it. Yeah. Absolutely. So welcome to the show, Doctor.
I appreciate it.
Yes, I am joined today by Dr. Rachel Selman, and we are going to talk all things pregnancy, pre-pregnancy, post-pregnancy, and getting back into being an athlete, whether you are an athlete for fun and recreation or a real actual going out there and competing, because we all want to get back to our activities that we were doing beforehand. So welcome to the show.
Thank you.
First off, tell me about, absolutely. Tell me a little bit about yourself. How did you become a physical therapist and what made you decide to jump into post and prenatal care?
Yeah. So I have always wanted to be a physical therapist. I mean, as long as I can remember, I even went to a career day with a physical therapist in 8th grade. Like I've always known that's what I wanted to do. I did not always know I wanted to do pelvic health. I graduated from PT school in 2016. I got my bachelor's degree in chemistry from Georgia Tech, which has not a lot to do with physical therapy, but you had to get your bachelor's in something. And then got my doctorate in physical therapy from Mercer University in 2016 and went straight into kind of like sports medicine, orthopedics. I've always played sports. And so I kind of thought that was where I wanted to settle. And I mean, I enjoyed working with that population. But then after about 2 years, I got pregnant and I was lifting quite a bit at that time. I wasn't doing tons of cardio, but I was doing a lot of like resistance training. And had been doing that for a while. I had built up a lot of muscle. And so when I got pregnant, of course, the first question was like, okay, well, how do I continue lifting? Do I need to modify? And it was so frustrating because everyone had a completely different answer. Like my OB said something different from my friends who had been pregnant, who said different things from, the pelvic PTs that I talked to and the personal trainers that I talked to. Everyone just had something completely different. And so super frustrating. But of course, I went with, the advice of my OB, because I think, that's generally what you should obviously do.
Right. That's who you trust the most.
Right. And it was my first pregnancy. And I think we probably can all laugh about the fact that we're a little neurotic in our first pregnancies because we just don't know it yet. We haven't been through it. Right. It's a totally new experience. And so I went with her advice, which was the most conservative advice, which I think we all kind of hear this still, even though we know it's bunk now, but the don't get your heart rate above 140, don't lift more than 25 pounds, avoid core work type stuff. So I did that. And obviously the first time I went to the gym with that in mind, I realized there's not a whole lot that I can do. You know what I mean?
Yeah.
I was lifting.
And when I first became a trainer, those were still the rules back then. And I would have pregnant clients that would come in with the old heart rate monitors that like went around their necks to make, oh, I'm at 142. I got to slow down.
Yeah. And so I wore a heart rate monitor for a little bit, and I usually would do like barbell back squats. And before I would do that, I would do some body weight, squats to just kind of warm up. And with the body weight squats, my heart rate was above 140. And I was like, well, now not only can I not do that because my heart rate, but the bar is 45 pounds, right? So I can't lift that. I've been lifting, back squatting. I was doing like 150 to 200 pounds. And it's like, okay, well, definitely can't do that anymore. So everything that I was doing, I basically had to stop or basically do a version of it that in no way was really actually serving me and my body. It was still significant detraining. So I lost tons and tons of muscle over that time.
And I'm sure just also from a psychological standpoint, you're going through the mental thing of, oh my gosh, I'm going to be a mother and change. Yeah. And now you're already having to change what makes you feel like you.
Right. And I think too, this is what I talk to a lot about my patients is like a lot of people are not trying to quote unquote bounce back, which I hate that term, but they're not trying to bounce back because they're like so concerned about what they look. They're trying to bounce back because they want to feel the way that they are used to feeling.
Right.
And obviously we know exercise has physical benefits, but the mental benefits as well, on top of the fact that I don't think it's a bad thing to have aesthetic goals, right? Like if you want to set some aesthetic goals and they're realistic and they're reasonable, and we're just as providers making sure that people are falling into, a reasonable, actionable area there, then that's not a problem. But I spent basically all of pregnancy losing tons of fitness, tons of muscle. And then postpartum, it was like the opposite. So it was this very wild, wild west of like, now you can kind of do whatever you want. And there was no like graded timeline of recovery. There was no stepwise process. It just was very much like, okay, for 6 weeks, you do nothing. And then at 6 weeks, you can suddenly do everything, which.
And they don't often do a pelvic exam at 6 weeks, correct?
No. Even my second that I just delivered in 2020, my follow-up visit postpartum at 6 weeks, I literally sat in the office for 5 minutes. They asked if I felt okay, if I was having any problems, and if I wanted to be on birth control. And that was my follow-up. We did not check anything. We didn't look at anything. And I will say disclaimer, I mean, they knew I was a pelvic floor PT, so maybe they kind of just thought like, oh, she knows how to do this. So I don't want to like bash them and saying like, maybe they do that for other people and they just did it for me. But I mean, what was, you know what I mean? Like what kind of follow-up is that? It's okay. You're medically stable.
Right.
Cool. But from a like athletic perspective, what should I be doing and what should I not? So postpartum, I rushed back because there was really nothing telling me not to. And I was so eager to get back because I had been like modifying for so long that I rushed back and created problems that I don't know that I would have had I not rushed that process. I just didn't respect the recovery process because none of my providers really did either. And there just wasn't great information out there. So I didn't respect the recovery process and ended up with some difficult situations because of that. Got really frustrated, ended up with one of my friends who was a pelvic PT, which should have used that earlier. I mean, she's one of my great friends and now she's one of my business partners, but I was in that same situation that probably a lot of your listeners are going to be in, where you're kind of like, I don't need that. You know what I mean?
Right.
Like I've been playing sports all my life. I know how to exercise. I know how to do these things. I don't need pelvic PT. Like, why would I?
It's just not something that's stressed to anybody coming up. Like,
right.
You get pregnant, you have the baby, you wait 6 weeks, you have sex and you exercise again.
Exactly. And so I just kind of thought, I don't need that. And I wish so bad that I had really used it as a resource. But I followed up with her when I started having some problems after trying to get back too quickly. And, she talked me like off a cliff because I was in a very like vulnerable, emotional, physical state at that time, talked me off that cliff and kind of gave me some things to work on. And now I'm largely symptom free. And so kind of obviously opened my eyes to like, man, this is like a totally different world that as a physical therapist, I know nothing about, which was just also wild that it's not something that's discussed even in physical therapy school. I do think that's changing, thankfully, but at the time I didn't know anything about it. And so I was like, I've got to, get better at this. And so I went and specialized and now have been doing that mostly for the past 5 years. So I've been doing that for a while now, and trend towards kind of a crossover between pelvic health and orthopedic health. I think it's interesting how we've put pelvic health in this box of like, oh, that's only pelvic health, and like, oh, it's not an orthopedic condition.
Right.
The pelvic floor muscles are they're muscles, right? Like we can exercise them, we can strengthen them, we can work on control and mobility. And if we don't strengthen them the way that we, strengthen our quads, they're not going to get stronger. They're muscles.
Right.
So
when I think people also forget that our body is one body and not compartmentalized. So if you're having pelvic floor issues, you could also be having feet issues. Like, I mean, there's
100%.
so much stuff that is tied together
100%.
that no one realizes.
And I think too, I get a lot of patients who will kind of call and are on edge about physical therapy because they don't really understand what it entails, which again, I get, we haven't done a great job as a profession advocating what we do. But when we start talking about, like, patients will tell me, well, I've been doing Kegels. Like, I know I've been doing my Kegels. It's so much bigger than that. Like, Kegels are a small piece of a very, very, very large puzzle. And so, yeah, like the first visit or two, I might make sure that you're doing that correctly, or that you're actually can do what I call like a reverse Kegel. Like, can you actually get out of a Kegel if you need to? Most of my patients, because they're very active, tend to rest in a little bit of a Kegel. And so if they keep doing more Kegels, it doesn't make it better. It actually makes it worse. And so the Kegels are important. I'm not going to say that they're not, but doing a Kegel laying on your back is not going to translate to jumping, running, etc. So, like
I love that you brought that up, because I think that a lot of people, we always think about having a weak pelvic floor, but like you said, a lot of people that are super, super active, which your clients, a lot of my listeners, often suffer from a tight pelvic floor, which can cause issues during pregnancy and after. Can you kind of talk about that real fast?
Yeah. So it's interesting that we kind of go down this rabbit hole, because too, even athletes that haven't had kids can have an overactive pelvic floor as well. Obviously can have an underactive one too, but most of like the gymnasts and dancers that I work with, like those athletes that really have to focus on keeping everything like together and tight and in line, they're constantly in this little contraction. And so I explain it to patients like a fist. So I need to be able to close my fist, but I also need to be able to open it. So if a closed fist is a Kegel and open fist is a nice relaxed muscle, I need to be able to do both of those things to get through my day-to-day life. The pelvic floor is no different. So if I'm one of those people who walks around in a little bit of a fist all day, and then my physical therapist tells me to go home and do 100 squeezes, I mean, I don't have anything left. One, there's no more room to squeeze, so I'm not really strengthening anything. And then two, if you were to kind of pry my fingers open after being clenched all day long, if you pried my fingers open and then tested my grip strength, I'm weak, right? Like just being in a clenched position doesn't mean that I'm super, super strong. It just means my body has kind of learned to rest in that position. And so in those cases, which again is a lot of the cases that I work with, Kegels are not the immediate answer. The first problem is like, we got to get you to relax. Like we have to figure out how to get your mobility back. I tell patients, if I had someone come in after an ACL repair and they only could bend their knee to 30 degrees, I wouldn't start them with jumps and squats and things like that. I'd get their mobility back first, and then we strengthen it. So yeah, eventually we'll do some Kegels, but when we do those Kegels, can we do them in like laying on our back? Can we do them in sitting? Can we do them standing? Can I do them when I'm jumping, hopping, running, laughing, coughing? And can I get my muscles to turn off when I'm not using them so that they're prepared to be actionable when I'm in those situations? So I think that's a big missing piece that a lot of people have kind of a misconception about the muscles, because all we know is Kegels. Most of the time when I do like workshops and stuff and I say a reverse Kegel, people are like, what are you talking about?
That's what I was going to ready to ask of, if you like, is there some kind of way to explain what a reverse, because in my mind, I'm thinking a reverse Kegel, go almost sit on the toilet as if you're trying to pee without peeing. But then I know that that's really bad for you to sit on the toilet for too long, because that puts
so
down
it's a fine line for sure. I think with reverse Kegels, usually my best cue, honestly, is kind of what you just said, but I'll say like pushing out a tampon. So the obviously vaginal opening, and because most of the people that I work with are pregnant or postpartum, that's usually the way that we go, because I have a lot of people, let's say, for example, in third trimester, if we relax the pelvic floor muscles, things can get out. So that's why when you say like, okay, when I go to the bathroom and I need to empty, if I'm trying to do a reverse Kegel, it would be opening all of those muscles so that things can get out. That same rule applies to baby too. So if I have patients who are like third trimester doing Kegel, and have never learned to open and relax, then they go to delivery and they can't relax the muscles to let baby out, that's problematic. And so I'll say like pushing out a tampon is generally the best cue. I have patients sit on their hand sometime and see if they can kind of feel a gentle push down into their hand, like feel those muscles push down into their hand. Mm-hmm. I also think sometimes if you visualize kind of the core, the belly, et cetera, as a balloon, if you inhale, like you're pulling in air through the nose, that belly should expand like a balloon. And if you think about a balloon, when it expands from the sides, it also drops at the bottom, right? Mm-hmm. So the sides are expanding, but the bottom also falls and pushes down into the surface beneath it. Mm-hmm. Then when you exhale, all that air goes out of the mouth, the balloon kind of contracts, and the bottom of the balloon will lift as well. That's how our pelvic floor generally works too. So when I'm trying to get patients connected to it, that's always a good place to start, is to tie in that inhale, exhale. Eventually, I want them to separate the two because I don't want them to have to think about it. My goal is when I discharge you, that you just go on a run and you don't think about what your pelvic floor is doing, because we know that it can work that way if we train it well.
Is one of your first steps to teach people just how to breathe? Because I feel like a lot of times we chest breathe versus abdominal breathe.
Yeah. And if I ask patients to take a nice deep inhale, most of the time they'll suck in. So suck the belly in, lift the shoulders, and they'll almost lift the pelvic floor with it, which is kind of the opposite of what we're really looking for. I do always clarify with breath work that the diaphragmatic breath that we're talking about, where you really expand the belly, et cetera. Yes, it is important when we're trying to get connected to these muscles, but I never want patients to think that they're like breathing wrong. You know what I mean? Right. We teach the extreme end of things because it makes the middle ground feel a little more natural. So when I teach patients, let's say, for example, who have neck pain, who sit with that really forward head posture, when we're working on that, like, okay, we practice a chin tuck. So that like really extreme, like, let's really strengthen these muscles on the front, pull back to that extreme posture. But I don't actually want you like sitting like that all day.
You're not going to walk around like this all day long.
Yeah. So I pull you into that posture so that like that middle ground feels a little more normal. It's kind of the goal with diaphragmatic breathing too, is like, let's get really in tune, really connected to what the body's doing. But don't go, around the rest of your day thinking that you're breathing poorly or you're breathing wrong or anything like that. The body's incredibly resilient. So if we can kind of like teach you those extremes, then eventually you fall somewhere more in the middle.
Gotcha. And you talk a lot in your paper about musculoskeletal changes in the body during pregnancy. And I think that's something a lot of people don't think about as well. Like, yes, we know that baby's going to be putting pressure on our pelvis and our cervix, and we know our belly is going to be growing. But what are some of the major changes through the trimesters that really happen to our body that we don't really think about, like widening of the ribs, for example?
Yeah. So I think first trimester is always, to me, the most interesting because it's not as visible, right? Like you don't see as many technical musculoskeletal changes. The belly is not looking pregnant. Largely at that point, the pelvic floor doesn't have tons of pressure on it. So I tell patients to think about their pelvic floor like a trampoline. And at first, again, you've got that little poppy seed sitting on top of your trampoline. Not going to make a huge, huge difference in terms of pressure there. The biggest things I think first trimester that you have to take into account are like all those hormonal changes. So for most people, the things that make them just feel fatigued and tired and weak and
nauseous
and I mean, just not like yourself at all. So it's not necessarily huge musculoskeletal changes in first trimester, but more of those like hormonal changes. Second trimester is obviously where that musculoskeletal change can really start coming into account. So again, that same trampoline, baby's getting a little bit heavier, a little more pressure on that trampoline, a little more stretch on those springs. And we've got belly starting to pull forward. So center of gravity pulls forward. Those ribs kind of start to flare a little bit. We get the booty tuck, like the mom clenched butt position, right? Because the belly is pulling forward. And then third trimester, that just becomes even more extreme. So by that point, usually baby is gaining a pretty good amount every week. And so baby just gets bigger. So that change from second trimester just becomes more problematic. For most of my moms that are exercising, I just have to tell them to be mindful of their bodies because your body's changing so quickly, especially halfway through second trimester through delivery day. I mean, I would wake up sometimes and be like, this is a completely different body than it was last night. So that's why we recommend things like, hey, change tasks that require movement of the barbell over the belly. So like a snatch, for example. Like it's not that the snatch itself is dangerous. It's not that it's going to cause problems, but we think we have a great understanding of our bodies in space, and we do. But when your body's changing that quickly, it's very hard for your brain to latch on. So like I would run into things all the time with my belly, like corners of the walls. I would try to squeeze in areas that I thought that I had room for, and then quickly realize like, I don't have room for this. So your body, especially if you're used to doing those things, it knows the bar path, right? It knows how far you're pushing that out. And so as belly gets bigger, it changes that bar path, and we're not always able to adjust that quickly. So it's not
and
that
when you come back, like I know, like Tia Claire Toomey right now, if you guys aren't listening, is the like CrossFit goat for women. And she's, gosh, what, 8 months pregnant now or something.
Yeah.
And she has said, like, I haven't been snatching except when she was doing the open and stuff, because I don't want to try to learn that curvature and then take that with me when I'm not pregnant anymore. And then I've got to build back up from learning proper form all over again.
Exactly. And that postpartum posture, I mean, it kind of persists. Like what you see third trimester for a lot of women when they come in for their postpartum visits, I still see that kind of clenched butt cheek position, which again feeds into that pelvic floor overactivity. You're constantly clenched, belly still pulls forward, ribs still kind of rest in that really flared out position. We lose that good ability to take a solid, deep diaphragmatic breath. And then again, I think I have patients on both sides of the spectrum here, but most of them end up on the overactive side. So, after pregnancy or after labor delivery, their pelvic floor goes into that like protection mode, because it's like, what just happened to me? So it goes to that like clenching. I'm just going to support you this way because I don't know that I have the control to do it another way. So it goes to that clench mode, and then they're not able to kind of contract and relax. The other end of that spectrum would be that they are in a nice relaxed position, but they don't have the quality of contraction that they would need to maintain stability when they lift, bend, twist. So like I compare that to my patients who have ACL repairs and come in and they can't squeeze their quad, right? You're like, hey, just squeeze your quad muscle. And it doesn't happen. So we use those little external pads, put them on there, have you squeeze both sides so that you can see the difference. The problem with the pelvic floor is you can't see it. And so it's one of those things where it's very easy to just kind of say like, it's fine. I'm sure I'm doing it right. You know what I mean? Until it becomes
normal.
Yeah, right. Totally.
So like the hormone relaxin, does that help relax the pelvic floor at all for people that are overly tight, or kind of like once you're not pregnant anymore and the relaxin goes away, do you just clench right back up?
So I think with relaxin, we still have so much to learn. And I always try to bring up the fact that relaxin, in terms of actual symptoms, we don't have anything specific right now tying the two together. So I have a lot of patients come in who kind of say like, oh, I know my relaxin is high, and because of that, I've been having like SI joint pain or pelvic girdle pain or things like that. As of right now, we don't have anything linking the two. So I'm always very clear with my patients, like your body is so resilient, your body is so adaptable, like it was made to do this. And maybe potentially relaxin has some kind of change, and obviously in terms of the ligaments, et cetera, but it's supposed to do that, right? Like it's supposed to help everything relax so that baby can get out a little bit easier. Right. That said, relaxin does tend to persist a little bit if you are nursing. And then there's some studies that show that those nursing hormones will kind of hang out for about 10 months after you stop nursing. So like for my patients who nurse their babies, let's just say a year, and then they're pregnant again by the time that, that 10 months after they stop nursing has passed, that relaxin is back in their system. So for a while, I think as a physical therapist, I did tell people like, hey, relaxin, everything's going to get unstable and kind of wacky and weird. But I think we're really trying to change the narrative on that a little bit, because we don't know that exactly that's the case. I do have patients who struggle with pelvic floor overactivity and feel like when they get pregnant that it does help. I'm not sure that I would be willing to say it's relaxin directly that does that. I also am not willing to say that it doesn't have any role in it. We just don't have good research on it right now. So I'm always very clear that as of right now, we don't directly link it to pain problems, et cetera. So I have, for example, patients who have like vulvodynia, which is just pain in the vulva area, sensitivity in the vulva area. And when they get pregnant, those hormonal changes can kind of make that go away. And there's not tons of research on why, but sometimes it makes it decrease a little bit. Everything kind of relaxes a little bit, feels better. So I think we've got a lot of work to do there, and I hope that that improves. But for right now, I just try to encourage my patients, like your body is so resilient, that pelvis is so resilient. There's so many different strategies that we can use to support it. So if relaxin is obviously present, and especially present in large amounts, let's just make you more robust, right? Like let's make you more stable. Let's compensate for that in this moment, instead of just kind of saying like, hey, this is something you have to deal with.
It blows my mind. This is totally off topic, but hearing you say like, women that get pregnant, sometimes symptoms go away. We don't really know why. Also brings the fact like some women can't eat gluten before they get pregnant, and all of a sudden they're pregnant and gluten doesn't have any issues anymore. And you're like, the body is so freaking amazing.
It's wild. So that actually happened to me with whey protein. So before my first pregnancy, I had a whey protein shake every day. I mean, every single day I had a whey protein shake, no problems whatsoever. After my first pregnancy, the first time I had a whey protein shake, I was like having difficulty swallowing. My throat felt like it was really swelling up, and I just kind of wrote it off like that's really bizarre. I ended up eventually having a barium swallow because I thought that something was like wrong. I wasn't linking the two because in my brain it was like there's no reason this should be happening.
Right.
And then I pinned it down. They were like, no, everything's fine. You probably have some kind of contact allergy, like whatever's coming in contact with your throat is causing problems. And it was every time I had whey protein. And so now, if I get a smoothie or something, I get a plant protein, like a pea protein, perfectly fine. But if they accidentally make it with whey protein, I literally now like carry an EpiPen and a steroid dose pack because my throat swells up so bad. And my OB, I kind of mentioned it and I was like, I know this sounds crazy and I feel like you're going to look at me like I'm crazy, but this is happening. And she was mentioning that, sometimes pregnancy hormones, et cetera, can kind of flip on certain allergens, flip off other allergens. And so she's kind of like, it sounds crazy, but it's not abnormal. It's not something that I've never heard before. So that happened to me. It's bizarre. No one told me that was going to happen.
Yeah, that's crazy. So kind of transitioning a little bit to this amazing research paper that you did, the old school, like we talked about at the very beginning, heart rate under 140, no lifting 25 pounds. I feel like over the past decade or so, things have really, every time I go, I don't have children, but every time I go, my doctor's like, what's your decision? Have you made the decision yet? And so it's been, my husband and I have been married for almost 13 years. So 13 years we've been having this talk. And when we were first talking about it, she's like, if you get pregnant, these are the parameters. So I've actually been around enough to see and to get a different talk from the doctor. Now it's more of like, just listen to your body. Your body knows what you can and can't do. You're used to working out heavy. Your body will tell you if you can't lift that, or, if you shouldn't be running that far or that hard. But there's still that idea of, at 6 weeks, you can still go back and do whatever you want. So I love that you've created Maximizing Recovery and Postpartum, like an actual timeline. How did you get involved in this research? And then let's kind of do the synopsis, because I know it would take like hours to go through everything, but kind of a breakdown of like first, second, third, and then fourth post baby trimester.
Yeah. So let's start with kind of what you mentioned about those old parameters. So the 140 thing, the 25 pounds, et cetera. The 140, I think, was a relatively arbitrary number. It was where kind of, I think most people maybe started to get a little bit like breathy, around 140 beats per minute. And so that was why that was kind of just initially, I think, selected. It was very arbitrary. Part of the problem you'll run into with research with pregnancy is obviously there are limitations of what we can do. We can't put mom and baby's safety on the line. And so for a while, things were just very conservative, trying to obviously make sure that we weren't doing any damage. So I think what we know now, obviously, is that it's more damaging for mom and baby to not participate in exercise because of all the benefits that mom and baby get from that exercise. So 140, I believe, was just kind of an arbitrary, like, this is where people start to get breathy. And so we're just going to limit it there. The 25 pounds thing was picked from a study that focused on women working basically in a warehouse type setting where they were lifting heavy boxes 8 to 10 hours a day over and over and over and over. And that being linked to some kind of potential birth issues or baby issues. And the thing is, most people aren't in that setting, right?
They're not
like if you
lifting
had a
8
job
to 10
where
hours, right?
Right. Like you're not lifting repeatedly 50 pounds overhead or over and over and over for 10 hours at a time every single day for your entire pregnancy. And so that's where that kind of 25 pound number originally came from. And then the core thing that we hear a lot is like avoid core work. Now we know, obviously, if you do the right core work, it's actually preventative in terms of the severity of some of those potential symptoms. So I think the conversation around diastasis recti and ab separation has completely changed in the past couple of years as well. So that's kind of where those numbers came from. And I think the part of the problem is that we're having with changing that kind of like stereotype and understanding is that it just takes forever for research to be kind of standardized. So for example, like if you do a research study on the research, you could have this great information that comes out, but even if it's wonderful information, it's not going to become standard of care for about 17 years. So even if we know all of these wonderful things, you still have doctors who are practicing who they weren't taught that in school, right? Because when they went to school, this is what the information that we had. And that's not
and they can't sit around reading every single new publication.
Right. And that's not necessarily their fault that they keep
Right.
teaching the things that they learned in school. I do think as providers, it's our job, to stay on top of things as best as we can. But like, I don't stay on top of medications, right? Like that's not my scope. So that's where, as a public health provider, I'm like, listen, if you're not sure what kind of advice to give someone who comes in who's pregnant and they're asking about exercise, and that's where you refer to someone who kind of that is their scope. So it's going to take a long time for that to actually stick. I will say I hear it less and less. I do feel like it's getting better. And like you said, most doctors will kind of say like, just go with how you feel, listen to your body type thing. The only problem I have with that advice is that we don't know how we feel. You know what I mean?
Right. Like hard is hard. Like, is it okay for it to be hard?
Hard is hard. And also, especially if it's your first pregnancy, like this is a totally new thing for me. So I understand you're telling me to listen to my body, but like, I don't know what's normal. I don't know what's not. And so listening to your body in pregnancy, postpartum is just not the best advice, because like, I don't know what any of this is supposed to feel like. So now, what used to be maybe an easy effort for me does feel really challenging. Does that mean I'm doing too much? Or having someone who can really walk you through that process, because you're already having to figure out a lot of stuff about how you feel on your own. So that's where I get frustrated with the listen to your body advice, because that's what I was told postpartum with my first, was just listen to your body. Okay, well, my body is itching to go on a run, right? I haven't gone on a run forever. I'm itching to go on a run. I'm finally starting to feel better. And then I went on that run. During the run, I felt great, right? Brain's like firing off all these chemicals. Like, this is so amazing. We haven't done this in so long. Look at you go. And then I came back and I felt horrific. So like the listen to your body advice didn't make sense for me, because this was a new body. I didn't know anything about it. It didn't feel like my body. It didn't move like my body. And from the outside, it looked fine, but I had this giant internal wound that I wasn't like taking good care of. I wasn't taking care of my muscles the way I should have been from a musculoskeletal rehab process. And so the just listen to your body advice, while I think it's definitely better than like basically telling people to be on bed rest, it doesn't serve women either. They need some kind of guided professional to help them understand what their body's going through. So I think that's incredibly important to make note of. In regards to the protocol came about because I was working so much in this field that most of my patients were pre or postnatal athletes. And there's Stacey Sims. She talks about how she classifies athletes. Basically, if you work out on purpose, that's how I classify them too. If you work out on purpose, you're an athlete. I'm not talking about you have to be an elite athlete to follow this protocol.
That's so funny. You're actually the second guest that I've had out of my past, actually two. My last guest brought Stacey Sims up, and I've been trying to get her on the show too.
She's amazing. She's doing incredible work. I feel like every podcast that I end up on, she's on it too. I feel like her and I, like, kind of what the information she pushes for and the information that I push for are very similar and overlapping in terms of kind of what we really do. Now, she is an absolute like specialist in her field. I have the utmost respect for her, but it's such a good adjunct to what we're talking about today.
Yes, for sure.
But she kind of talks about, if you exercise on purpose, you're an athlete. I would agree with that. So anytime with listeners, I'm always clear, like if you're going to the gym in the morning or you're making time to, exercise, you are an athlete. And so what was happening was, because so much of my patient population was pre-postnatal athletes, I would have other PTs reach out to me and say like, hey, I've got this person. She's 4 months pregnant. She's having some low back pain. What could I do or not do? Or people would reach out to me and say like, hey, I just had a baby. Like, what could I be doing that would be helpful? And so I was constantly answering these questions for people, which I do not mind because I'm all about education. But I was like, I wish that there was just, like a set of guidelines that I could send you and kind of say, here's a general idea. And if you don't fall into this pattern, then go, find a specialist, get some individual one-on-one help. And so I kind of created it like almost just on my own selfishly to kind of say like, okay, when people ask me, what should I be doing per trimester and what should I be focusing on postpartum, then I can just kind of send them this table and kind of say like, here's generally what I will tell my patients. And if something in here doesn't feel right, then we dig into it a little bit deeper. And so kind of condensed all of that and then shared it with the clinicians in the clinic that I worked with, because they were also kind of helping with some public health stuff. And so I shared it with them. And then we were all like, why isn't this available for everyone? You know what I mean? Like, it's great that it's here and it's great that it's available for the people that are asking me questions. But at the same time, like, our providers should generally be on some kind of similar wavelength. The other challenge was that I would get frustrated that when I would go talk to doctors and encourage them to, send women who were pregnant or postpartum, I didn't have anything to take with me. I didn't have anything to say like, hey, here's the research. Here's what it looks like. Here's what we do. It was just kind of like, hey, take me at my word, send patients. I promise they'll feel better.
Right.
And as great as that is, it's not objective, right? It's not objective data. It's not something that like shows the scope and the intensity of what we do. And so I started taking that with me and saying like, here's my general kind of programming. Like, here's what I teach women to do. Here's the things we work on. I really think your patients would benefit. And having that in front of them, I think was a wake up call of like, man, you guys do a lot of different things in there.
Yeah.
And so I think it kind of helped start that conversation as well. So once we started kind of talking about it more and more, I was like, I really wish that just more people had access to it. And so we went through International Journal of Sports Medicine. And I actually, when I submitted it to them, I said, listen, I understand that this is a sports journal. I'm talking about postnatal athletes and pelvic health. And I know that, you know, this is not something that you'll typically find in a sports journal, because most sports journals are baseball throwing mechanics or, you know, things like that. And so I was like, I get that this doesn't exactly fit with your journal, but I think it should. Here's why. And I kind of said, you know, if we get rejected, then we'll go from there. We'll figure it out. But they took it. And so took that on and kind of published that. So that was just October of 2022 that it finally got published. So thankfully,
and I love it that it's like a scholarly paper, but for anybody can read it and understand it. It's not like, here's the abstract and you're like, wait, what did I just read?
Yeah, that was the hope, because that's really who it was for, right? It's for the providers and it's for the patients who are trying to kind of understand what their body's going through. So I pulled on a couple people that I really trusted and felt like would be good contributors. So Brianna Battles, who's a strength and conditioning coach. Dr. Kate Early is an exercise physiologist. I've got Dr. Misty Seidenberg, who's another physical therapist. And then I've got Elizabeth Wendell, who's a urologist, and Susie Westerland, who was a OBGYN. So someone from all of those different scopes, you know what I mean, to look at this and say like, hey, if I'm a urologist, I'm looking at this, would I disagree with anything that this physical therapist is doing? And if so, why? And that way I could pin down, like, let's get out all the providers on the same page and kind of say like, hey, here's a very general protocol. So again, when I talk about this protocol, I'm always very clear. I'm very much in a protocol situation where like, if something works for 75% of people, 75% of the time, then that's what we're going to go with. Let's be honest that not every protocol is going to work for every person. So when we put this out there and we put timelines on it and said like, hey, here's things you could do starting at 2 weeks postpartum, at 3 weeks postpartum, at 4 weeks postpartum, it's not going to work for everyone. There's going to be people who don't fall into that timeline or who don't even want to think about rehab until they're 6 months postpartum. I am not rushing those people. Like, I just want to be clear on that. This is just for those people who are like itching to get back, who don't know what to do, who need a process for that athlete brain of like, here's something I could do to be moving in the right direction. And then that timeline tells them, here's the earliest I would start it. So like the earliest I would really want to get back to running is probably about 10 to 12 weeks or so postpartum. And so if someone had just told me that, like, hey, listen, here's things you could work on that would help set you up for success, and here's the earliest I would do it, I think that would have made a real difference for me. Because my brain and the way my brain works is like, if you tell me like to work on diaphragmatic breathing, and I'm going to skip that. You know what I mean?
Right.
Like,
nobody wants to do the boring stuff.
No one wants to do that. Like, it's boring. It's not fun. I get it, but it's foundational. It's incredibly important. And so if you tell me, listen, you can't run till 12 weeks anyways, right? Here's some things you could be doing that will set you up for success when you run. And here's the absolute minimum timeline you need. Then that to me checks a little box in my brain. So I wrote it the way, selfishly, again, the way that I would have wanted to have something. And thankfully, I think a lot of other people kind of resonate with that thought process. But I'm always very clear that a protocol is a protocol. And there are going to be people who don't fall within those timelines. And that is perfectly fine. It does not mean you're messed up. But even if you start, you know, let's say 4 months postpartum, you still need to start with step one. You still got to start with the basics. So even if you spend the first 4 months doing nothing because you're just connecting with your baby, which is perfectly fine, you still got to start with step one. You don't just get to go to step, 12 weeks and jump straight into it. You skip the foundation of your house.
Sure.
So that's kind of what it looks like. But if you, the paper essentially has trimester by trimester. So answering kind of the last question that you brought up here, trimester by trimester, what things do I focus on when a patient comes in? So in those situations where a patient comes in and they just want preventative care, like I just want to know things I could be doing that will set me up for success. First trimester is mainly just work around symptoms, right? Like, let's just get you moving in any way that we can, any way that feels good to you. Let's talk about what your body's about to go through. Let's talk about the educational piece of it. Let's talk about your posture. Let's talk about, how to use that RPE, that rate of perceived exertion scale, so that you can use that as you start to exercise. Second trimester, body starts to change a little bit, but it's a great place to get strong, right? Generally, people feel good there. So let's get strong. Let's get coordinated. Let's really connect to those muscles, those deep core muscles, those pelvic floor muscles that we don't spend a lot of time on outside of pregnancy. Because if I can get you to have a better connection there during pregnancy, it's going to be much easier to connect after pregnancy, as opposed to trying to teach you to use a muscle you've never used. Now it's dysfunctional because it just created this human and pushed this human out of your body. So now we're trying to activate a dysfunctional muscle. Stage or trimester 3 would be more like, okay, let's figure out how to make sure that we can really relax the muscles so that baby can get out. Let's continue to focus on strength. Remember, the ACSM guidelines are still the same as everybody else, right? 150 minutes per week, 2 to 3 resistance training days a week. I want to continue those things in a way that sets you up for success. So
now, could you still do 75 minutes of vigorous exercise instead, or would you say no on that part?
I'm glad that you asked that, because this is, I think, a hot topic right now. And I think it's on the way to changing. So right now in the United States, at least, we don't have that in our pregnancy guidelines. So that 75 minutes of vigorous activity is not necessarily recommended for pregnancy. You'll see it's okay to get breathy, but not breathless, moderate's fine. Vigorous is too much. That said, there's a lot more research coming out, I think, about this, in that there's actually some studies showing that if people exercise vigorously, if they're used to it, right, if they were doing it before and now they're still exercising vigorously, that they actually have longer pregnancies. So they actually is the opposite, I think, of what most people are told, hey, you're going to have your baby early. Their pregnancies actually last a couple of days longer. And I believe it was Australia that just put out that they are fine recommending that 75 minutes of vigorous activity. So some interesting changes there, but I know that there's that video floating around of a while of that girl running a 5-minute mile when she was
I did see that. Yeah.
So she ran a 5-minute mile at 9 months pregnant. And I mean, from a medical standpoint, I don't think we really have anything saying that that's necessarily dangerous. Is it the best for your pelvic floor? Probably not. Right now, you've got a watermelon bouncing on that trampoline, but at the same time, I haven't done an exam on her, right? She could have a crazy, strong, coordinated pelvic floor that really supports that baby. And she could do that 5-minute mile. And that's 5 minutes of obviously vigorous activity.
And I think a lot of people are questioning it too, because it's okay, yeah, it's a 5-minute mile. She's probably not running a 5-minute mile every day. So, that 5 minutes out of her entire trimester, how much stress does that really put on it?
Exactly.
I know, again, Tia Claire Toomey, not to bring her up, but I know that there's a lot of people are, raising eyebrows at her. And that's what she has been saying too. I'm not snatching every day. I snatched for this 5-minute competition and moved on.
Exactly. So that dosage is important. Your athlete's important. It's a very individual process. And so again, with a protocol, it is a general protocol, but if you look at physical therapy world, we have protocols for everything else. We have protocols for rotator cuff repair, ACL repair. There's timelines that kind of say, by week 6, we should have this much amount of bend in the knee or this much amount of external rotation in the shoulder. Is everyone going to fit in that protocol? No, absolutely not. But we still have them because it gives us a general idea of kind of where to go, what to be working on, et cetera, et cetera. So third trimester is a lot of coordination focus, pelvic floor relaxation, mobility work, again, postural work, because your posture is changing so much. And then postpartum, it kind of walks through week by week, because you change so much postpartum and you change so quickly, because you go from carrying a baby around to now you don't have a baby, but your uterus is still about the same size, right? So it takes about 6 weeks for that to go back down. And then now we've got a different amount of coordination because these muscles have been totally stretched to the max. Doesn't mean that they're not going to respond. Doesn't mean that they're not going to build back stronger. I think a lot of my athletes actually are stronger after baby because they really put in the work of connecting to the deep core and connecting to the pelvic floor. And I have athletes who, have never done that work, and they say they're 45, 50, 55, low back pain, have never used their pelvic floor in their life. And so I've got these athletes that come back with, okay, I know how to use these muscles now. And you'll see all these moms setting all these world records. It's crazy.
It's
they're
crazy.
Crushing it. I think the person who just won the Hawaii Ironman, she had a 1-year-old or something.
Oh, I don't know. I will look that up and post it down.
I'm pretty sure she had a 1-year-old and just went out there and absolutely crushed it. wild, wild, wild. So I think we're just
and according to the protocol, it's not as if you're saying you're just going to sit with baby for 6 weeks. If you're feeling up to it, I mean, you're saying 0 to 2 weeks, start working on your diaphragmatic breathing, start doing little things to help you set up for success.
Little things, little mobility work. The problem is we've been left in the dark for 0 to 6 weeks of like, hey, there's not really anything you need to do. You just need to rest.
Right.
And I'm not against rest. But again, if I repaired your ACL, I would not tell you to rest for 6 weeks. Yeah, I want you to heal and I want you to be easy with it, but I'm still going to send you to physical therapy, get you moving, get blood flow going, start moving you in that recovery process to go from nothing for 0 to 6 weeks. And then suddenly at 6 weeks, like, hey, you can do whatever you want. We're setting people up for failure. Absolutely.
Right.
And then
I also feel like it's also setting up for moms who, once they get that okay to exercise, for the past 6 to, let's say, 10 weeks, they haven't been doing it. And so it's so hard to fit into their schedule. Whereas if they start spending a little bit of time, just 10 to 20 minutes a day on these simple things that help set them up, they've already mapped out that time of their day to do something for themselves.
Right. Exactly. And it just helps, again, like for me and the way that my brain works, it would have just been so nice to have like a checklist. Like, okay, I know that I'm not, out there with pushing a barbell, and I know I'm not going on a heavy run, but I do know I'm working towards that. Whereas I think 0 to 6 weeks, when you don't have guidance, it's very much like, I'm not doing anything. Like, I don't feel like myself. And again, I don't want any mom to feel this way, but this is how I felt because it's just how my brain works. It's like, okay, well, I'm being lazy. You know what I mean? I'm not doing anything. I'm not helping myself for future Rachel, for future babies. You know what I mean? So like having something that's like, listen, this is what you can do if you're feeling well and things are going well. Here's some movements that you can work on. Then that would have checked a box for me that at least would have made me feel like I was moving in the right direction, as opposed to just, again, being kind of left in the dark until boom, 6 weeks. Now, if you want to go run a marathon, go run a marathon.
Right. And also takes away some of the doubt because you are more confident in your body because you've been working it versus at that 6 week mark being like, well, the doctor said I'm okay, but this is going to be really nerve wracking for me. Am I actually okay?
Exactly. And I think there is a fear component of people like learning about their pelvic floor, because I hear patients all the time say, well, I'm terrified to mess up my pelvic floor. Okay, well, if we started working on connecting to that at like 2 weeks postpartum and you knew how to do that before you had your baby, because we talked about it, we walked through it, you felt comfortable, confident. I did a home follow-up with you at 2 weeks postpartum. We checked it out. Okay, cool. It's working. Here's what you can start doing to strengthen it. Great. Then by the time that you do get cleared and you do go to the gym, you don't have that like, I wonder if my pelvic floor is working. I haven't had anybody check it. I don't really know what that actually feels like. And then that fear comes in, which is part of this education, right? Like the more information gets out, there are going to be people who are like, that freaks me out. Like, I don't know how to check that myself. So that's why working with someone who really does know how to kind of help support you in that is incredibly important as well. So I think that's a huge piece of it that we just really, really miss.
I know that we're coming through time. I know that you have to see some patients today, but kind of to finish off, do you think that having a pelvic floor specialist for postnatal care should be the standard of care? Like every OBGYN should almost be like, have the doulas, have the midwives, have a pelvic floor specialist all in house.
Absolutely. Absolutely. I mean, if it were any other muscle, again, do you recommend physical therapy after an ACL repair? 100%
it's
of the
standard
time.
of care.
Right? It's standard. Exactly. You just get sent, and it is standard of care in some countries. I think the UK now, and this could be wrong, so don't quote me on this. I think UK, I think Germany, and I think Australia also now have standard physical therapy. And a lot of it is at your house. So like after you have your baby, they come to your house, they treat you in your house. And that makes a world of difference. And it's one of those things where our healthcare system is so reactive. And so it's like, okay, well, when you're, 50 and you're still having leaking, then we could talk about maybe surgery or something like that. Whereas like, well, I could have fixed this, 30 years ago if I had had the proper care.
And I knew better.
And if I knew better and knew what to do. And so I say all the time, I'm trying to eliminate the phrase, like, I wish I had known, because I do work with people who are 20, 30, 40 years postpartum and just kind of thought the symptoms they were living with were normal. And it's not that we can't fix them down the line. It's just that you shouldn't have had to suffer with this for decades.
Right.
Because the information was bad and we didn't talk about it. So I don't get frustrated with providers that, don't understand or don't know anything about pelvic PT. I do get frustrated when providers tell patients that they don't need it, because I don't think they quite understand what we do, which is part of why I wanted to put this out there. So I had something, again, to take with me when I'm talking to someone and saying, look, this is what we do. And this is why we do it. This is why it works. I get frustrated when I have patients go and they say, well, I asked and I said that I would like a referral and they wouldn't give me one. That's problematic.
Sure.
I mean, it's one thing if you're telling patients to go and they choose not to pursue it. Totally get that. That's on you. Life is crazy. It can get expensive. I completely understand. But as providers, we shouldn't be telling people that's not going to work for you. Like, you don't need that. Like, just don't worry about it. It should be something at a minimum. Let's do a screen. Let's check it out. You know, worst comes to worst, you come see me and everything works perfectly fine. And then we say like, all right, great. You go do you. Here's some ideas that you can get started on. But that I wish I had known thing really, really irks me.
Yeah. My last question, if somebody is pregnant, they're trying to get pregnant, no matter where they are in their pregnancy, when would you recommend them getting started? Should they wait till after delivery to come see you or right from the get-go?
So I really recommend if they're feeling fabulous, like if everything's going really well, they're not having any pain, et cetera, just once per trimester, like once first trimester, once second trimester, once third trimester, obviously kind of towards the beginning of the trimester. Let's talk about what this trimester is going to look like for you, what changes you're going to see, what I want you to be working on, some goals that you can set in terms of activity, et cetera, because it does change just a little bit as you obviously your body changes, et cetera. And then usually postpartum, I like to follow up in home around 2 weeks postpartum. That gives you a couple weeks to just get settled, get home, and then I'll come to you. Like, don't lug your baby out. Like, let me come to you. Let's check your scar. Let's check your incision. We won't do any internal work at that point because you're not cleared for internal work. I'm not trying to contradict anything that we've, been told. I just want to see how you're moving and make sure that, when you hold baby, does your posture look good? How's your back feel? Like, can I work on it for a little bit to make you feel better? What kind of mobility stuff can you be doing to set yourself up for success? And then follow up. On average, I would say like 4 to 6 visits postpartum. So like starting at 2 weeks, I'll come to your house and then you come like maybe every 2 weeks or so, just check in. And that gets you through that 12-week mark. So 6 visits over 12 weeks gets you to the 12-week mark. And if we've been progressing, in a really easy, straightforward way, cool. At 12 weeks, you hopefully feel great and we can start easing back into it. So you'll see in that paper, there's a return to running protocol. That return to running protocol, we don't really implement until 12 weeks. And it's a 12-week return to running protocol. So we're not, in our case, just as providers, we're not saying like, hey, go back to full running at 12 weeks. What we're saying is like, hey, at 12 weeks, you can start and you need to ease into it and be smart about it. So here's a program you could follow for 12 weeks. Gotcha. So that gets you 3 weeks or 3 months of recovery, rehab, et cetera. And then 3 months of like build yourself back up to what you were doing before. So you're looking at like a 6-month plan. And that's if everything's going fabulous. And honestly, most times there's something thrown in there. There's going to be a wrench thrown in there. There's going to be a grade 3 tear or a mom who has like 3 months where she can't get rehab done because it's just her baby has colic and he's up all night. And we get
or
that.
Like my best friend who got pregnant just a few months after delivering.
Yeah, exactly. And so it doesn't always work that way, but that's where a professional comes in and can kind of say, let's tweak this a little bit for you. Sure. Like you only had a grade 1 tear, right? You had a little bit of a skin tear, whereas this patient had a grade 4 tear, a complete muscle tear. We might need to add a little bit of time to this protocol compared to this person, right? So someone to kind of guide you through that. So the protocol, like I said, was meant for that purpose, but then with the help of a licensed professional who can kind of say like, let's tweak this so it's more individual to you.
Love it. And you guys listening, I will make sure to link the actual protocol down below. So it's super easy. You can go read it. Like I said, it's like we talked about, it's easy to digest and it's written out in a way where like, okay, this week I do this week I can do this. Of course, listen to your body because it's not for everybody. Everyone's on their own timeline, but I love it. Now, Rachel, do you just work with clients in Charlotte or do you work with people virtually as well?
I can do virtual appointments as well for a certain state. So if anyone's ever interested in like a consult type thing, they can always send me an email and I can help them kind of troubleshoot if that's an option or not. So if they go to synthesisphysicaltherapy.com, there's a contact thing at the bottom. They just scroll down and can send me a message, or Synthesis Physical Therapy on Instagram. They can DM me there as well. That's perfectly fine. I also, we do have an app called Stirrups to Sit-Ups. So there's an Instagram for that as well.
That's awesome.
That app is basically the protocol, but in video form. So that's what my friend that was a pelvic PT, her and I kind of went on that together. So it's called Stirrups to Sit-Ups. It's actually through Fitter. So FITR. So if people are looking for it, they'll download the Fitter FITR app, and then they'll search for the Stirrups to Sit-Ups program. So it's a program within a kind of pre-existing app. So they can find it that way, or if they go to stirrups2situps.com and enter their email, we'll send them all the information as well. But it starts at literally day 0, right? Like you have your baby, you open your app and it tells you like day 0, there's not exercises, right? I'm not having you do jumping jacks, but it tells you here's how to hold your baby. Here's how to pick up the car seat. Here's how to roll out of bed, things that you need at that point that can kind of help you. And let's say you're 3 weeks postpartum and you're like, I'm finally feeling like getting started. You can still do the app and still start at day 0 and just start learning that information, building your way up. So it starts day by day and it starts technically at day 0. But I still tell patients if they haven't done a rehab program, download the app and just start at the beginning and start working your way up. And that app is a very, again, general timeline. It's pulled from that paper. But if they notice symptoms during those exercises, that's a kind of like, hey, let me get this taken care of now, as opposed to like, let's just assume it's normal and I'll get it taken care of, 6 months down the road. So it kind of gives you some insight too along the way. Like, are things going the way that I would expect them to be going? Or do I feel like I'm behind? Do I feel like this is way too challenging for me? Do I feel like this causes pain? That gives you an opportunity to kind of check in with how you're doing and get in touch with the provider at the right time if you need to.
Gotcha. And I love what you kept saying, like normal. And I think it's important. And in the protocol, you say this a lot too, of just because it's common doesn't mean it's normal.
Right. So I think the biggest thing that's been interesting to me in terms of getting connected with patients is moms are so good about talking to other moms about symptoms. So they talk about it a lot. And so that culture around how we talk about this really matters. And that's why I think that these kinds of podcasts are so important, because it teaches people like, hey, wait a second. Like, we just had brunch last week. We were talking about how I went to the trampoline park and peed on myself. And we all laughed about it because we all do it, instead of somebody being like, hey, I got physical therapy for that, and now I don't do that anymore.
And now I don't do it. Exactly.
Yeah. And so that conversation is incredibly important. So I think that's why, again, I think that these conversations are so important, because it will change the narrative. And again, it's not going to change from the research for probably another like 20 years or so. So our generation is going to have to kind of advocate for ourselves. So that's where these pieces really come in.
I love it. Well, thank you so much for taking time out of your patient day to come and hang out with me. I really appreciate it. That was awesome. You guys, make sure, go check her out. I will have all of your links down below in the show notes. So go research, read the entire protocol. Whether you're pregnant, you've already had your babies, you're not planning on having babies, I still feel like all women in general should be familiar with this stuff to, again, like you said, spread the word, get the information out there. Because even though I have no babies, all of my friends do. And now I get to pass this on to them.
Yeah, you're right on track. I appreciate it.
Right. Absolutely. Thank you so much. Have a great day.
Thank you. You do the same.
All right.
Bye, girl.
Bye. How awesome was that interview? You could tell just how passionate Dr. Selman is on getting the word out on the timeline of recovery and how important it is to find that bit of you. I feel like a lot of people feel like they're lost after they have a baby. They feel like a part of their identity has changed. Whereas when you do things correctly, you can get back into doing some of the things that you use to define who you are. So I really love this episode. Again, even if you plan on never having a baby, or whether your baby is 10 years old, hopefully you found something interesting in this episode. All of the show notes and the links to the report are down below. And if you love this episode, please feel free to share it with your friends and family, share the Fit Women's Weekly podcast, comment down below. And then if you want to help support the channel, do it by doing those things. Feel free to follow me over on Instagram at Kendall Boyle Fitness. But what I'd really love to see is you try out Fit Women's Weekly Live, which is my online training studio for women who want to get strong, who want to be pushed farther than what they're used to getting pushed. Online workouts will only get you so far unless you're doing the right online workouts, and that's where I come in. So I'm going to have the link down below for fitwomensweekly.com. You can find out more about that, and there's also other ways that you can help support the podcast. All right, you guys, I'll be back next week. Thank you.